specialty conferences. Now we invite Dr. Harish Shetty to introduce today's speaker, Dr. Jojo Kotur. Harish sir.
Good morning, friends. It gives me, thank you, Dr. Sonal, Snehal,
Thank you,
for the introduction. And it gives me great pleasure and honor to introduce the speaker for today, one of the most talented clinician, Professor Dr. Jojo Kotur. Dr. Jojo is an academician, a clinician of international repute in the field of restorative dentistry and endodontics. He is a graduate of Sri Mukambika Institute of Dental Sciences, Kanyakumari. Later, he proceeded to Chennai to do his master's in the specialty of endodontics at Meenakshi Ammal Dental College. Presently, he is working as a professor at Royal Dental College, Kerala. Dr. Jojo, in his illustrious career of more than a decade, has about 37 publications, that is PubMed publications. He has a citation of more than 1,000. Believe me, friends, you heard it right. More than 1,000 citations already. It shows the kind of commitment this young gentleman has, the kind of publication he is doing in the specialty. He is the first author worldwide to report the complexities of 7 and 8 root canal system in maxillary first molar and 4 root canals in the maxillary lateral incisor. And this featured in the 7th edition of, that is the 50th anniversary edition of one of the, we can say, the mother of textbooks, Ingalls, that is 7th edition. Believe me, in our days when we were doing PG, probably, you know, if I can say, if Shashi Kapoor was an endodontist in Diva movie, you would have said, "Mere paas Ingle hai." You know, that is the kind of book you can imagine. And this man is already featured in that. 13 of his publications appeared in this 50th anniversary of Ingle textbook that speaks volumes about this gentleman, the kind of work he's doing. He is already been recognized by the various associations. The Indian Association Conservative Dentistry and Endodontics awarded him the Best Reviewer for the year 2015. And they followed it up with the Clinical Excellence Award in the year 2018. And again, another award called as a Rising Star Award. I'm sure none of you are surprised. Those who follow him in social networks, they know him, the kind of work he does. I'm also one of his fans. I also follow him very closely. He's been doing wonderful work. And I'm so glad I've been given this opportunity to introduce him today. His present focus is on biomimetic tooth restorations and retreatment in endodontics and painless procedures. I can go on and on about Dr. Jojo, but I know for a fact there are 800 odd people waiting to listen to Dr. Jojo, and I don't want to take more time. And I, along with my co-coordinator, Dr. Snehal and Dr. Rajesh, present to you, gentlemen, Dr. Jojo Kotur. Dr. Jojo, please take over with his topic for today is newer concepts of access cavity preparation. Over to Dr. Jojo.
Thank you, Harish sir. I have been introduced in various platforms, but an introduction like this is something special. So I would like to thank you in person for such a kind introduction.
Thanks.
Let's move on to the presentation, shall we?
Yes, sir.
The screen is visible, right?
Yes, sir. Screen
Yes.
is visible.
Okay. So shall I? Shall
Yes,
I
sir. You
start?
can start.
So very good morning to all the viewers. And first of all, let me thank uh, Pratibha ma'am for inviting me to this particular lecture. In addition, I would like to thank the coordinators, Dr. Rajesh and Dr. Sneha, for doing all the preparatory works for this wonderful series, E-Link. In addition, it's a very pleasure. It's very good to have the IACD and IES president together in this particular platform. So very happy to see Vibha ma'am and Vivek sir together and wishing their best for this particular conference. So without wasting much time, let's move on to the presentation. As Harish sir had mentioned, I will be speaking about recent concepts of access cavity preparation. When I was a postgraduate student, we used to do a lot of wax opening, and Harish sir had mentioned about few of my articles, that is aid root canal system article. And here is a picture of the access opening and the post observation radiograph. Now, these access opening were done according to the knowledge which is available at that point of time. That is before the Clark and Academic Classic article. This was done in 2007, guided by my teachers over there. Now, what are traditional endodontic axes? It's very simple. It's a predetermined shape. That is, we say for a lower molar, we have to do triangular axis. For upper also, it could be a trapezoidal. And we have to do straight line axis. It should be a flared preparation. And we should get the convenience form. And you can see many other articles of mine which was published in the same era between 2007 and 2011. If you look into these post-operative radiograph, you can see I had completely acknowledged the mechanical and biological objectives of root canal treatment. What is mechanical? Mechanical means I had cleaned and shaped all the root canal system. Uh, I don't think anyone will disagree with that I missed a canal in these cases. What is biological? Biological means I had popped out all the bacteria and microorganisms from the root canal system. So these are the mechanical and biological objectives of doing a root canal treatment. But I'm a little skeptical about the functional objective when I look into these cases which I had done a decade back. I'm a little skeptical about whether these teeth are still in function. Because if you look into access opening, my main target was to identify the canals and do a good root canal treatment. I was not well aware at that time about the functional objective. And these type of root canal, even if it is performed well, can lead to fracture. Now you can see a well-treated tooth had ended up in a focal radiolucency. And this was because of vertical root fracture. Now, if you assess the primary reason for such fractures in the form of cracked tooth syndrome or vertical root fracture, there is a beautiful article published in the year 2006 by Anil Kishan in endodontic topics, and he had classified fractures that can happen to an endodontically treated tooth into primary and secondary. Now, if you look into the primary causes of fracture, you can see the primary reason which he cited uh, for the reason for the tooth to fracture is tooth structural loss. And it has been substantiated in many other classic articles that preservation of sound tooth structure is one of the most important aspects for tooth survival. Now, let's uh, see the journey in which these things had happened. That is, how to preserve the tooth structure and try to avoid these type of catastrophic fracture over a long period of time. We are looking for a longer outcome for root canal treatment, right? I mean, the functional, the biological, the outcome. We don't want the root canal treatment to fail in function after 5 years or 10 years. We want it to stay probably for more than a decade, or modern endodontics say we have to do root canal treatment that can last for the lifetime. So it's not about a failure, but also the function. The function of the tooth should be established for a longer period of time. So the journey on tooth conservation on access cavity starts with this particular classic article, which came when I was finally a postgraduate student at Meenakshi Malden College by David Clark and Jordan Academy. It's a classic article. All of you should read this article. It's a highly recommended article. That is a modern molar endodontic access and directed dentin conservation. So I'm not going into detail about this article, but I would like to put two important parameters that uh, Clark and Kadami had put forth when we do the modern endodontic access. The number one is that they said that we need to conserve pericervical dentin, or we call it as PCD. Number two, they recommended to create something called Soffit. So let's discuss the first one, that is the pericervical dentin, or PCD. What is this PCD exactly? The pericervical dentin is actually the dentin located 4 mm above and 4 mm below the crestal bone. So the dentin surrounding this portion, we call it as PCD. It is not only on the outside of the tooth, but also inside of the tooth also the PCD is there. Now, the question is, what is the importance of this PCD? If you want to know the importance, again, an article by Anil Kishan published in endodontics topic in 2006, the same article had stressed the importance of having the importance of PCD, that is the functional stress. When the tooth is in function, the majority of the functional stress is distributed primarily towards the cervical portion of the tooth. And that is exactly the PCD. So PCD actually is occupying the cervical portion of the tooth. So I had mentioned what is PCD and its significance. Now, this is a clinical case of mine, which I have done during my clinical practice. This is how we evolve in time. So you have a similar case, two similar case, a mandibular first molar here and here, a very long root. And in the case number one, you can see I have done a good root canal treatment and a post-endodontic filling. And the case number two, that is this one, again, a similar root canal and a post-endodontic filling was done. Now, if you look very carefully, what is the difference between these two? I think everyone agree. I had looked into tooth conservation in the form of access cavity and shaping. Now here you can see a lot of flaring of root canal, and you can also appreciate that the PCD is very much compromised in this case, whereas here you can see the PCD is preserved because I didn't do an orifice shapers here, and I had used special instruments to instrument this root canal. And look at the access cavity also, it is more conservative than this one. So this is how we evolve with time, by updating the knowledge, understanding our mistakes, and try to overcome that with passion. So that's about the PCD. The second is about Soffit preservation. Now, what is actually the Soffit? So traditional access say we need to remove uh, the roof of the pulp chamber. You can see this is the roof of the pulp chamber. But the modern access, that is a Clark and Kadami article, say we need to maintain a small border of the pulp chamber roof around the uh, access cavity. So you can see the roof was not completely removed. It is there all around. So that particular remaining roof, we call it as soffit. Now, what is the importance of Soffit? I had mentioned a significance of PCD. So likewise, I'm going to illustrate the importance of preserving the soffit. Now, you might have heard about I-beam. I-beams are very popular beams in structural engineering. Now, these I-beams are not very popular nowadays because we have gone to a different level of construction now. But when you see the old bridges across in Kerala, we have a lot of old bridges which was constructed by British. That is the cast iron bridges. So if you look into those bridges, you can witness the I-beam. Now, the I-beam principle, it's an engineering principle. You have the flange here, which resist compressive force, and you have the I-beam here at the center, which actually resists the shear force. So when you have an eye and a flange, it actually prevents the compressive force and shear force to cause catastrophic. Claim is there is endodontic with a centroid, and the distance from the centroid to the flange actually determines the resistance of the I-beam. So if the distance is more, the resistance is more. Now, this same principle is applied to the tooth. We have the centroid towards the floor of the pulp chamber. And when we preserve the soffit, this two side will act as the flange. And this particular phenomenon, if you try to incorporate in access cavity, will prevent bending of the tooth during function. So that's the significance of preserving the soffit. Now let's move on and discuss what enable us in performing minimal invasive access cavity. Because traditionally probably for many years, we were de-roofing the pulp chamber. The primary reason why we de-roof is to get the convenience form. The convenience for identifying the canal, the convenience for doing better instrumentation, the convenience form for better irrigation, debridement. So it's all majorly on convenience form. That is, it's more of operator centric. So the things had changed now, and let's see what is a major change that had happened in order us to enable performing such minimally invasive access cavity. So the armamentarium required to perform these access, number one is ST mirrors. It's not about front surface mirror. ST mirrors are mirrors that have the ability to reflect 40% more light than a regular front surface mirror. So we have this now. Number two, we have to make use of 3 handpieces. The number one is a low speed 1:1 quadrangle handpiece, which we generally use for finishing and polishing composite restoration. I also recommend to have a high speed 1:5 quadrangle handpiece, and definitely you need an air turbine handpiece. So you start entering the pulp chamber with a air turbine handpiece. That's what I do whenever I go for these minimal invasive access cavities. Later, I move to either a low speed or a high speed quadrangle handpiece in order to do the refinement. So we need these 3 handpieces. Number 3, we need special burrs. We need definitely a round burr to enter the axis, and a safe-ended burr is also mandatory to modify the access cavity. And a flame-shaped burr, which is being shown here, is used to give a calla lily preparation, because we need to bevel the enamel. Otherwise, there will be rough margin towards the enamel, because we are going to preserve the enamel in these access cavities. And when we instrument, there is high chance that the instrument hits the enamel margin, and that can lead to fracture. So you can bevel the enamel a little bit when you do these access. Especially designed aerotor burrs has been designed by Clark, proposed by Clark, and was designed by SS White Company. And these are called the EG series burrs. These are aerotor burrs, conical shaped aerotor burrs, specifically designed to do these minimally invasive access cavity. In addition, I would recommend to have the Muntz burr. And if you don't have the Muntz burr, you can buy the surgical tungsten carbide burrs for modifying the access cavity for the refinement. So you have, if you have money, you can buy Muntz, or if you are doing a regular practice, you can buy the rotor, I mean the micromotor regular burrs. The fourth instrument that we should have is the ultrasonic tip. Definitely, ultrasonic is going to have a huge impact in doing minimal invasive access cavities. In addition, we have to rely more on ultrasonic activation or other techniques, because something is being compromised when we do minimal invasive access cavity, and that is disinfection. So we don't want that to go for a compromise. So definitely you should make use of the activation systems available in your kit. Here you can see I'm activating with Nerisave in a minimally invasive access cavity. The fifth armamentarium, what we require is a files in the form of hand files and rotary files. So you can see we need special uh, hand file holding devices. These are hand file holding devices because our access is limited to the pulp chamber. So we don't want our hand to come and obscure the vision. So it is better to have hand file holding devices or probably micro openers and a grinder in your office to identify the canal. Number 6, we need explorers. Now, you know, the classic explorer, what we use is DG16. DG stands for David Green, or you can see JW17 Explorer, John West number 17. Now, this is a very handy tool. I will show you what is the difficulty, what we face when we do the minimal invasive access cavity in the coming slide. Number 7, CBCT, because many a time when you have a constricted access cavity, we cannot see the floor wall junction. If you look into the loss of orifice location proposed by Krasner and Ranko, in a minimal invasive access cavity, you won't be able to visualize this loss because we are not seeing the pulp chamber properly. We are not seeing the floor wall junction properly. So it's very difficult to find the jumping into these access cavity. And limited FOV CBCT looks very promising in endodontics. The radiation had effective radiation dosage had come up very less. And I would say in the future, maybe in another 5-10 years, uh, CBCT is a routine thing that should be implemented in all dental offices. Number 8 is the heat-treated regressive taper files. Now, you may be wondering what is a regressive taper file. Now, there is something called maximum fluid diameter for a file, that is the diameter at the orifice. Now, this is a conventional instrument. This is an F2 instrument. You can see at D16, the diameter is 1.20. Now, if you use these instruments, it is going to consume the PCD. So that's why these regressive taper instrument had come. It is maintaining the same tip diameter, but when it comes to the orifice, you can see the diameter had gone to half, that is 0.69. So these are called the regressive tapered instrument. The classic example of that instrument is the DC taper instrument, again from SS White. Now, SS White is a company which gives a lot of instruments for minimal invasive access cavity preparation. The number 9, obviously we need magnification. Without magnification, it is impossible to do these minimal invasive access cavity. I would highly recommend to have a microscope. A loop is satisfactory, but yes, it will be a compromised treatment if you have a limited magnification. And the last factor, which is very important for doing minimal invasive access cavity, is the time. Now, you can't hurry your treatment. You can't take up maybe 5-10 patients a day. In my experience, if you're doing these practice, you can take maximum 4 or 5 patients a day because it's really time consuming to finish these access cavities. Now let's discuss these access cavities available in in the literature various minimal invasive access cavity. You have the conservative access cavity, you have the ninja ultra conservative or mouse hole access cavities, we have the caries-driven access cavity, we have the truss access cavity, we have stepped access cavity, you have constricted or contracted access cavity, and finally we have the Facebook access cavity. I usually call it as Facebook access cavities because nowadays people are uh, running behind in getting attention in social media platform, and I had seen many fascinating artistic access cavity which doesn't have any evidence in endodontic literature in various social media platforms. So let's discuss one by one. We start with the guided endodontic access cavity. Now this looks very promising according to me. What they do is they take a pre-CT scan, they make a template, and the template have a, a path for the bird to transit, and this is specifically indicated in managing calcified canals. So if you have a calcified canal, clinician skill is a very important factor in tackling it. And if you're not skilled, if you don't have the armamentarium, most of the time we end up in an iatrogen giraffe. So I would highly recommend that this will be the future in managing these calcified or obliterated root canals in endodontics. Uh, in addition, there are few literature available about this guided endodontics. This is an article published recently in 2020. What they assessed is that they had assessed the guided root canal preparation in 50 patients, and the result is all cases lead to location and negotiation of root canal with precision. That is, it doesn't end up in any iatrogen chiro. Now, if you are doing, or if I am doing 50 cases of fully obliterated canal, I'm not really confident in tackling it in 100% efficiency. So this looks promising, not in regular endodontics, at least in special scenarios of managing dense invagination or calcified root canals and many more. Recently, there are few had questioned the importance of guided endodontics. What they claimed is it is limited to anterior teeth. That's true. We can't put these templates and drill for posterior teeth, calcified tooth, but it is very much limited to the anterior teeth. Even though there are few articles came up recently in 2021, which they shown a guided endodontic preparation on a maxillary molar also. The second drawback of this is the crack formation. That is, we are using special drills without water. So crack formation and heat generation is a major drawback when it comes to these guided endodontic. But in spite of these drawbacks, the advantage actually outweigh the disadvantage of this particular procedure. And to your knowledge, let me add this particular article. It is called a dynamic navigation technique, wherein they use optical triangulation tracking system and stereoscopic motion tracking cameras, and we will be able to visualize the path of the burr in real time. Isn't it beautiful? That means the problem with guided endodontics is we are not seeing the tooth. But this dynamic navigation technique, which is being proposed in 2020 in endodontics, and a lot of research is happening right now in this field, wherein we will be able to see the penetration of the burr in real time, the depth, the pathway, the angle, everything we can visualize in a monitor. And that's a promising thing that can happen in the future. Is conservative access cavity. Now, it relies on two principles. Number one, preserve the pulp horn, and number two, slightly converge. We need to preserve the soffit, but not much, but definitely you need to preserve some amount of soffit. So let's see a case which wherein I had tried to do a conservative access cavity preparation. So this is an intentional root canal treatment. You can see an intact maxillary second molar. We should always look for the point of entry in these cases with the radiograph. So the point of entry is exactly at the center and you can see the pulp chamber is placed exactly at the center. So this have to be visualized before initiating the treatment. And we need a good isolation and a good magnification. So the point of entry for me is here. And this is how I started with the axis. I used the smallest round burr and tried to penetrate the center of the tooth in an angulation that is parallel to the long axis of the tooth and with the highest magnification. Now, this is after the axis cavity. You can see I had directed directly to the pulp chamber, and this where you use ultrasonic tips, or you can use these Muntz burrs or other micromotor burrs to flare the root canal towards the chamber. That means when towards the occlusal surface, the root canal that the axis cavity should be converging slightly. So that is how the conservative axis cavity looks. And then we put the orifice shapers and the rotary instruments to clean and shave the root canals. But we visualize these root canal by tilting the mouth mirror. You can see that. We won't be able to see the root canals in one shot, but we tilt it. And one of the major drawback you can see here, the pulp remnants under the soffit, I really find it difficult to remove it completely. Even if we agitate it, even if we use sophisticated explorer, this is a challenging aspect to remove the bacteria and debris that is hiding under the soffit. It's very difficult to remove for a clinician. As I had mentioned, we have to use a lot of irrigants because disinfection is something that is being compromised in these minimal invasive access cavity. So here I am using a 30 gauge needle. The penetration is also difficult because we have limited access cavity. So recently there is an article published in GOE. They assessed the potential of syringe irrigation in minimally invasive access cavity, and they find it is very difficult to do a good syringe irrigation in these minimally invasive access cavity. I had already mentioned we have to activate the irrigant. Here I'm trying to activate with the resave, and this is the final outcome. And you can see the 3 orifices. This is because of the water, the presence of water. Otherwise, we won't be able to see the 3 orifices together. And then we obturate. We need the highest magnification in order to obturate with the thermoplastic technique in these cases. This is after observation, and this is the post-op radiograph. Now, I could able to do a decent job here, and you can see the criteria of access. I have preserved the soffit to the maximum extent, and more importantly, you can see the access cavity is converging occlusally. And this is the after the post-endodontic restoration. Now, next move on to the ultra-conservative access cavity, the next in the minimal invasive access cavity. Now, what is the difference between conservative and ultra-conservative access cavity? In ultra-conservative access cavity, we do extreme unroofing of the pulp chamber. So we still have to unroof it, but it should be very minimal in such a way that only one single burr is go into the pulp chamber. And the smallest of possible opening that can get achieved with a round burr should be used in these ultra conservative endodontic access cavity. Now here is a case of mine, uh, uh, a second mandibular molar. Obviously I had planned for a minimal invasive access cavity, so we should again assess the point of entry. I always insist all of you to make sure that we find the point of entry when we do these access cavity. This is a clinical picture, so I'm gonna do the point of entry here with the smallest burr available. And you can see it's a round burr penetration directly into the pulp chamber. You can see the size of the access cavity. I hadn't enlarged anything more. And if you put a rubber stopper, you can see the rubber stopper is 3 times larger than the access cavity. So I hope you can imagine the size of the access cavity which I had prepared. And we follow the same protocol which I had shown you before, and we obturated. And this is a post-op radiograph. Now you can appreciate the soffit here. It is two-dimensional image. Actually, the Soffit is there three-dimensionally all around. So let's move on to the next access cavity, that is the opportunistic endodontic access cavity, or we call it as caries-driven access cavity. Now, what are these access cavities? So this is nothing but if you have an existing decay or a restoration, we try to do root access through those cavity or restoration. We remove the restoration or we remove the decay and we get into the pulp chamber. This is also applicable on cervical caries. If you have a cervical caries or non-caries cervical lesion, we don't need to do an access cavity from the top. We can access the pulp chamber from the cervical lesion, from the buccal side, and finish the preparation. So that's called the caries-driven or an opportunistic endodontic access. So let's see a case. Here is a first molar. You can see big decay towards the distal aspect, secondary decay under the amalgam towards the mesial aspect. So this is the clinical image. You can see the amalgam and the huge subgingival decay towards the palatal aspect or palatodistally, more specifically. I removed all the decay and restoration, and you can see this much tooth I need to remove in order to make the tooth clean from the bacteria and the decay. So once this is being removed, we try to find the root canals from these opening which we already had created. So we try to find the palatal canal through this aspect, and we try to find the mesiobuccal, distobuccal, and through this particular side, that is from the mesial side. So here you can see the cavity which I had prepared. From this side, I identified the palatal, and from this side, I identify mesiobuccal 1 and 2 and the distobuccal. So the center portion is still remaining there, and we fill it. Now this is of strategic importance. You know why? Because if you look very carefully, this much is the tooth structure remaining after the removal of the amalgam and the decay distally. Now, in a conventional access cavity, that is the traditional access cavity, we do like this. And when we do the crown, what is remaining? We remove the whole tooth structure, what is remaining there. So the functional objective of a root canal treatment done with traditional access cavity in these compromised teeth is really questionable, even if you do a post-endodontic building in the proper way. And this is the post-op radiograph of this image. You can see a well-observated root canal, and more importantly, a good post-endodontic restoration. The next in the line of minimal invasive access cavity is something called the stepped endodontic access cavity. Now, what is stepped endodontic access cavity? It is also an opportunistic access cavity, but it is slightly different. For example, if you have a large composite restoration which is intact, what we do is we remove the composite restoration completely, and then we do an ultra-conservative access cavity. So that is called a stepped access. That means it involves two steps. Number one, remove the restoration. Number two, go into the pulp chamber with the minimal access. So it's similar to what we had discussed before, but it is a different concept. So that's why we call it a stepped endodontic access cavity. Next, we have the orifice-directed endodontic access cavity or truss endodontic access cavity. Now, what are these? So what we do here is we create separate cavity towards different roots of molar. For example, if it is mandibular molar, we do two access cavity, one directing towards the mesial root, the other directing towards the distal root. In addition, we don't remove the dentin that is remaining in between these two cavities, and this remaining roof we call it as the truss. So the truss of dentin is there between these two separate cavities, and that's why we call it as the truss access cavity. Let's see an example. Here is a periodontally involved tooth. It's a primary periodontal secondary endodontic involvement. So my periodontist asked me to do a very minimal access cavity because this patient is not going for a crown in the near future. We need to finish the periodontal part, then only we can prosthetically rehabilitate that tooth. So I had done a truss access here. I had directed a cavity towards the distal, another one towards the mesial, You can see mesiobuccal and mesiolingual and the distal canal. And this is a poster radiograph. Looks very beautiful, right? But to be honest, I really find it difficult to remove the pulp stone, which is under the truss. I can see the pulp stone here. Probably I might have spent around 15-20 minutes in order to remove the pulp stone from the truss. And that's why we will be able to get this beautiful picture, because otherwise the post-endodontic filling is not going to go under the truss. Now, here is another case of mine. Again, I was trying to do a truss access here. You can see a lot of calcification on the pulp chamber. I started with the truss, but I really find it difficult to remove the calcification. Sometimes we get attached pulp stones, which is really difficult to remove with the ultrasonic tip. And finally, I have to take off the truss. I had gone to a conservative access cavity and try to finish the root canal. Another potential complication of or problem, or I would say disadvantage of these minimal invasive access cavity is illustrated in this case. Again, a case of mine. I was trying to do a root canal treatment with the minimal invasive access cavity. So this is the caries, and I removed the caries, and I done a opportunistic access here because I tried to enter through the caries lesion. You can see the minimal invasive access here. And when I had done the post-endodontic filling, you can see the filling hadn't reached the pulp horn here. That's another drawback of minimal invasive access cavity. It's not easy to put the composite into the soffit. And I would say, in a clinical perspective, I'm a little skeptical about the light curing ability of this portion. Already we need to angulate the light cure unit in a very peculiar manner, and literature is very much proven that you need to make sure the light cure unit is as close as possible to the restoration in order to get a good polymerization. So the number one, there is insufficient penetration of the composite resin. Number two, I'm little skeptical really about the polymerization process that had happened at this particular site. So I have to remove the post-endodontic filling, and I had used some activation with ultrasonic in order to make sure the composite goes into this soffit, and that's why I could able to do it. So that's another advantage of it. So generally, the benefits and the possible drawbacks of conservative access cavity have been the topic of extensive research from 2010. I would say that a lot of article is being published now, and I would say it is one of the hottest topic right now in the field of restorative dentistry and endodontics. That's all these biomimetic, bioemulation, bioceramic, everything is all about biomimetics. So it's more of tooth preservation. So let's discuss the evidence. Now, when it comes to the minimal invasive access cavity, the major advantage that the proponents claim is the fracture resistance. Now, there are contrary articles regarding the fracture resistance. These two articles says that teeth with the conservative endodontic access and the ninja endodontic cavity show similar fracture strength, which was higher than the teeth with traditional endodontic access cavity. But in another article, they had found that the conservative endodontic cavity did not increase the fracture resistance of teeth compared with ones prepared with traditional endodontic access cavity. So there are contrary results. Few says that conservative access cavity or ninja access cavity give better fracture resistance, but there are many articles contrary to that particular finding. So let's discuss a few systematic reviews, one published in 2018 and the other one published in 2021, what they say. And now, according to these systematic review on in vitro studies, we still don't have a randomized controlled trial on minimal invasive access cavity. So all these systematic reviews were done taking into account of all the in vitro studies that was performed for the past decade. And they found that there is no scientific evidence that supports the use of the conservative endodontic cavities over traditional endodontic cavity for the increase of fracture resistance in human teeth. So there's no evidence to support that when we perform these minimal invasive access cavity, it's going to substantially improve the fracture resistance of the tooth. Again, a recent article published in Journal of Endodontics 2011, it's a review article. The finding is almost similar. The conclusion was there is a lack of evidence that minimally invasive access cavity design will improve the fracture resistance of root canal treated teeth. Again, various other aspects has also been studied, like root canal and this article said traditional endodontic cavities may lead to better preservation of original canal anatomy compared with the conservative access cavity. And they also assess the filling ability, that is how good you can three-dimensionally fill the root canal. And again, the result was not promising. There is significantly more voids in root canals when we do with. They also tried to assess the truss access cavity, which we have discussed on the disinfection ability. And the conclusion was the pulp chamber retained a significantly higher percentage of remaining pulp tissue in teeth with truss access cavity. This is what I was showing you in the clinical pictures. That is, it is very difficult to clean the soffit, even though we have sophisticated ultrasonic tips. Even I had modified the explorers to clean it. It is still a very challenging task to be performed clinically. Now, if you look into literature, these are the published articles in minimal invasive access cavity, and it's very clear that the abbreviations and terms used to classify different types of access cavity. Some may call it as truss access, some may call it as ultra conservative, some may call ninja, and there is a huge difference in the way we claim this is a particular type of minimal invasive access cavity. And that's why, to be honest, there is no consensus on how to define different type of access cavity, because we have a plethora of access cavity right now in the endodontic literature. And that is what this particular article had tried to acknowledge. They tried to propose a nomenclature to give a standardization on the future studies that can be done with minimal invasive access cavity. And they had classified it beautifully, like traditional access cavity for anterior, the conservative access cavity, the ultra conservative from the incisal edge, the caries-driven, and the respiratory-driven. And to be honest, this is again a clinical case of mine, which I was trying to do an intentional root canal treatment for this canine because of trauma from occlusion and periapical pathology. So I tried to take an incisal access cavity here. You can see I'm trying to penetrate from the incisal edge rather than the traditional approach of above the cingulum. Now, literature is very evident that it is good for us to move from the traditional access to the incisal edge, because even if you do a good access here, the major concern for a clinician is the aesthetics, because when the patient smiles, sometimes the restoration is visible. But I don't think that's a problem in this current era, because the composites had improved a lot, I mean, very much, and it is easy for us to put a restoration in such a way that it is not visible when the patient smiles. So literature is very evident to move our access cavity from the traditional position to the cingulum, and done a very minimal access and obturation here. And you can see the post-op radiograph here. So I would highly recommend to move from the traditional access to the incisal edge access cavity when you were dealing with the anterior tooth. And the same manuscript had standardized the terminologies to be used for access cavity preparation for posterior tooth also. Later, Isufi had also had, and the team also had published an article They also try to classify the various type of access, but in a different perspective. What they had done is they had classified according to the percentage of volume of dentin and enamel removed. And they classified as 15%. If it is 15% removal, it is traditional endodontic cavity. If it is less than 15%, it is the conservative access cavity. And if it is less than 6%, we can call it as the ultra conservative endodontic access cavity. So I had listed out all the access cavities available right now in the endodontic literature, and I had shown my own cases and had told the difficulties which I had encountered when I tried to use these access cavity in my clinical practice. Now let's see the drawbacks. So number one, there is high chance of missing a root canal. Number two, we will jeopardize the disinfection. Even if you do a gent irrigation protocol, I would say we will compromise in irrigant penetration. There will be damping of ultrasonic energy because the ultrasonic tip is going to touch the root canal, and definitely we are going to wet the needle because we don't have different path of insertion for the needle into the root canal. And finally, there is an increase of treatment time. I told you that you can't finish these root canals in 45 minutes. I would say a clinician, as a clinician, I'm saying it will take more than an hour if you want to finish a root canal with minimal invasive access cavity. So I would like to end the presentation with a story which was told to me by one of my mentor, and he told that long back when Shielder was teaching in dental schools, one fine morning Shielder came to the classroom and told the students, "Hey guys, you want to see the best access cavity in the world?" And everyone was really curious to see that access cavity because Shielder is telling, I'm going to show you the best access cavity in the world. And he had shown a access cavity like this. And everyone asked, what is the specialty of this access? This is the access that we all do. And Shielder says, yes, this is the best access cavity because if you want to call something as the best access cavity, it should be teachable, number one. That means it's not only me, someone else can do that. Number two, it is repeatable. That means I have to do it 1, 2, 3, 4, 5, 6, like that. And also it should be predictable. So teachability, predictability, and repeatability is a very important characteristic of an endodontic access cavity according to me. And I'm little skeptical about these minimal invasive access cavity will satisfy all these criteria at this current uh, era. Now, the take-home message of the presentation will be, we still missing the long-term data, even to support or deny these called minimal invasive access cavities. But I'm really optimistic that sooner or later, minimal invasive techniques will be the future. That much I can guarantee. And minimal invasive access cavity is very technique sensitive and it is largely dependent on operator skill. And I would like to highlight this. Not everyone can do that. You need real operator skill to perform these access cavity without iatrogenic error. So the take home message will be, do the type of access that make me do good cleaning, shaping and irrigation. That's what I generally do. I don't stick on to minimal invasive access cavity in all case. I change according to the scenario. Wherein I find it difficult, I do go for a traditional access. But whenever we have a chance in tooth conservation, do a conservative access cavity. So that's the protocol which I would like to recommend to all of you. And this guided endodontics I had mentioned before looks very promising in the future era. So with this, I would like to end my short presentation on minimal invasive access cavity. We generally call access is success because that's the starting of root canal treatment. So, I had tried to incorporate all various audience who are listening to this lecture, postgraduates, academicians, undergraduates, interns, and many more. And thank you all for the patient listening. If you have any queries regarding this particular topic, you can contact me in any of the modules which I had shown you here. You can contact me via email, or you can contact me in the Facebook page, Root Canal Point, or Insta, Jojo Kotur. And a few of my presentation is also available in YouTube, Jojo Kotur. So I would say make use of these platform if you have to rectify any of the doubts regarding this particular topic. So over to the organizers.
Thank you, sir. Thank you for sharing your valuable experience and tips on this vast topic of recent concept of access cavity preparation. I'm sure all the viewers have been benefited by your pearls of wisdom, as access cavity preparation is the preliminary step of endodontic therapy. Also, access cavity is of paramount importance as it is vital stage that governs the success and gives ease to the operator for subsequent treatment stages. Thank you once again, Dr. Jojo Kotu, for such an informative session. Thank you, sir. Now I request moderator Dr. Harish Shetty to take up the queries from participants.
Thank you
Over
so
to
much.
you, Harish, sir.
Yes. Yeah, thank you, Dr. Snehal. Dr. Jojo, I should thank you again for the wonderful presentation there. You have given a beautiful insight into what is in store for us, the younger generation, what they can expect, what they should concentrate. And it is always said, when there are no questions, either they are not understood, or probably they never heard you. And I am seeing the number of questions pouring in here. I can tell you, your deliberation today has provoked so much of thought process in the young minds here. I don't know how many questions I can take up. Probably I'll try to, post few questions for at least 4 or 5. Let me come out with the first one. It says, generally after root canal treatment, we advise a prosthodontic crown. Since we are going in terms of micro conservative preparations as access cavity, especially in class 1 type of cavities, which way do you recommend crowns? Do you recommend crown at all, or what should be a post endodontic restoration?
Again, that's again a change in era again from crowns to the indirects. So when I started practicing dentistry, I only heard about crowns back in early 2000. And when I entered my post-graduation, I learned about inlays, onlays, and all those things. But that's not something that we used to do routinely. But from 2010 to 2020, something had evolved dramatically, and that's a addition dentistry. So it's very easy to bond a ceramic or an indirect composite to structure. So probably I would say in my practice, almost 70 to 80% of post root canal treated tooth, I don't do crowns. But there are certain specific indication for crown. For example, a tooth already had a crown. You have to put a crown only there. Then number two, if it is very minimal tooth structure remaining, we don't have much enamel, the bonding is compromised. So in that case, I do something called verti prep crowns. It's not a horizontal prep. I specifically do verti preps wherein the margins will be below the composites. So that's a specific protocol that I follow in my practice. But the ratio, if you ask me, I would say it is around 70-30. I don't do crowns in 70% of post root canal treated tooth, but maybe 30%, yes. I do a lot of re-root canal treatment in my practice. So all these tooth already had a crown, so definitely you don't have any other option, so you have to put a crown again.
Thank you, Dr. Jojo. I hope that I should answer the question there. And the other question is asked, since PDC, Periservical dentin is the most important aspect what we concentrate to conserve today, how do you really justify truss preparations? Because there we try to save the enamel or the dentin, and probably at the cost of biological, compromising is also there, which you also mentioned in your talk. So how do we really justify truss preparation? The other question.
I didn't get, sir. What justifying the means?
In the sense, is truss preparation is something we should do, because as you mentioned in your talk also, removing a calcified structure is much difficult. So how exactly this truss preparation is justified?
There is lack of evidence to justify it in terms of, I mean, available evidence right now. That's why I said there is no one-stop solution. In my practice, I try to conserve the tooth structure. That's the main motto right now. So I move on to a biometric type of practice right now. My primary focus is that. Now, having said that, you can't do truss access in all tooth. In certain case, like I had shown in the second part, there are certain cases in which the disinfection it will be compromised. So in that case, I will take off the truss. So we can't say a one-stop solution that in these cases we can do truss access. But my message will be try to do as minimally invasive as possible in the form of truss or ultra conservative or conservative, which is possible from your side. But if you feel it is going to compromise the primary objective of root canal treatment, that is three-dimensional disinfection and filling, you remove the truss or whatever you are trying to achieve.
Thank you, Dr. Jude. I hope that should answer the question there. Probably, I think what I can put in a nutshell is Dr. Jojo is saying you have to be thinking endodontist rather than with the prefixed ideas. So, according to the situation, probably you have to adapt to the situation and change the concepts as and when it's required. That's what I believe Dr. Jojo conveys. And other question is there any special equipments to reach the unreached area, especially when you're doing the composite curing? Since you mentioned about curing is difficult with this Soffit concept.
To be honest, there is no much equipment, but what we can do is we have light transmitting wedges, right? So what I generally do is I put the light transmitting wedge inside the composite and then light cure. So this light transmitting wedge, I assume the light transmitting wedge is going to absorb the light and go in, and it gives into the chamber. And that's why I think that will help in better polymerization. But these are all hypothesis or assumption, but there's no proven record to that. So that's what and I had shown you in the case that I'm really skeptical about the polymerization of these composites inside the Soffit.
Thank you, Dr. Jojo. I think Dr. Jojo's technical that is the one area probably where the young researchers have to really think over. Probably a lot of scope there to come out with an equipment which can reach these unreachable areas. That's what I believe you're trying to tell us. And the next question is, what is can you please again show the micromotor burrs you showed for conservative calibrations? If you could just put it across or.
The micromotor burrs is long shank tungsten carbide burrs. See, that's from Mani actually. That's actually a surgical burr. You know, for surgery, they specifically give tungsten carbide round burrs for creating the cutting the bone. So that's what I use. That's a very economical thing rather than investing on these ultrasonic tips, which is in an Indian pricing tag, we won't be able to afford such sophisticated instruments. So this is something that can be used in routine practice. From Mani, micromotor burr for surgery, surgical procedures.
Okay. Thank you, Dr. Jojo. But just to add, it is the question from my side. You did mention about using your oral surgery burrs, long shank burrs. You mentioned about that. How exactly you use that?
Oral surgery, that would be
surgical burrs ways. I thought you mentioned something about that. No, what sir. They use in surgical procedure.
When we attaching to a straight handpiece, right?
Yeah, correct. Did you mention something?
That here. Because
okay.
Triangling.
All right. So this is
cut. If you are directly cutting, then it's fine. We need triangle, so we need a micromotor burr. We can't use
surgical. Okay. So there's the query regarding that was whether how to use the old surgical burrs for the endo procedure. So I think you're mentioning about the surgical burrs, not the straight burrs what to be used with the straight handpiece.
Correct.
Okay. So, Dr. Rajesh, do you have time for a couple of more questions, or we can?
Yes, sir, you can continue with the questions.
Two, three more questions you can take, sir.
All right. Okay. Another question is about does ultrasonic, when used without water, have any effect on migraine and vertigo patients?
Oh,
I don't know whether this really fits in here, but this is another.
my expertise, I would say. If someone can put a light on it, I'd be happy to hear it. I
All
didn't
right.
see anything on that.
So, yeah, I think we'll keep these questions for, for the.
Trying to do all these minimal access cavity for the entire day will result in vertigo and migraine for the operator.
Yeah, we'll try to address that question through physicians there. One more question says, what is the benefit of getting access cavity in anteriors through the incisal edge?
Because it is proven in many studies that when we take access from the lingual aspect, the access cavity and the root canal is not oriented in the same direction. You understood? So we need to remove more tooth structure. That's why we cut more lingually, right? When we do the regular access, we have to take the burr lingually. So we are removing more tooth structure. But if you draw a line through the long axis of root canal, the line actually comes out through the incisal edge.
Absolutely. I think
so quite logical that the minimal invasive access have to be taken through the incisal edge.
Thank you, Dr. Judah. I think that should.
We don't do that because we have amalgam. We don't want the amalgam on the front teeth, right? So that's why we don't do it. So literature is sufficient to move from our traditional to incisal edge right now.
Okay, I think we'll come to the last question. It says, is there any special irrigation protocol in minimal or ultra minimal access cavity preparations?
Yeah, I told you disinfection is something that is compromised here. We need to rely on other adjunct irrigant techniques like ultrasonics, sonic or ultrasonic, or laser activated irrigation if it's available. So you need to rely on all these adjunct irrigation protocol to maximize disinfection. And I would also recommend to put an intracanal medicament because it also maximizes the disinfection. That's another way in which you can achieve disinfection if you're dealing with a necrotic tooth.
Okay, thank you, Dr. Jojo. I think that should answer the question there. I think I should thank you once again for your patience and very nicely for postgraduate student and the clinician you explained. I'm sure their queries have been answered well. Thank you once again, and over to Dr. Rajesh and Dr. Snehal for.
Thank you so much, Jojo sir and Hari sir, for your valuable insights. Lastly, on the behalf of Department of Conservative Dentistry and Endodontics, we would like to give a certificate of appreciation to our speaker, Dr. Jojo Kottu. Sir, kindly accept this.
Thank you. Accepted with thanks.
And moderator, Dr. Harish sir. Kindly accept this certificate, sir.
Thank you so much. It's a pleasure.